the standard of care so far is a drug called sorafenib. And sorafenib has been kind of studied extensively in regard to hepatocellular carcinoma. And the most critical study is what we call the SHARP trial that randomized patients with advanced liver cancer with Child-Pugh A to either sorafenib or placebo. And the outcome of the study was an important improvement in survival, both clinically and statistically, that led to the approval of the drug to be the standard of care. I have to admit, in a way, Richard and I have an easy job because it's the only drug that's approved for HCC. So all what you have to say, remember the word sorafenib. But truly not. Actually, there are some challenges. There are some questions. I think sorafenib answered the question to a standard of care, established a rapport to some kind of base we can go back to when we were trying to do research. Actually, one of the debates before even sorafenib was approved is like, what's the standard of care? What do you compare to? So at least this was answered, but appropriately so, we didn't really cure patients. And definitely I think this opens multiple questions in regard to management of sorafenib as well as other therapies. So let's start to dissect a little bit of the management of the sorafenib. I mentioned the phase 3 trial that it applied mainly to child or to all Child-Pugh A patients. So let me start with Richard, Child-Pugh B patient, sorafenib.
That's an excellent question. The SHARP study was designed to show that sorafenib was an anti-cancer drug and minimized that risk of liver dysfunction, and it improved overall survival. Now we come to the real world outside of a clinical study, which all of us in the clinic need to deal with, is a patient who does not fit that perfect paradigm of well-compensated liver disease. The challenge as patients' liver disease gets worse is, can we make a difference in how long they live? Even if we control their tumor, will they still just die at the same date from their liver disease? And the data does not exist that we could improve someone's survival with the use of sorafenib outside of the Child-Pugh A population. But there is a group of patients who I think we all recognize. They walk into clinic, their bilirubin might be a little high, or they have some fluid retention, they're on Lasix, and it's hard to say, I'm not going to give you any treatment, right? Because the sense is, maybe if we could slow down your tumor progression, which I think is essentially how sorafenib works. We don't see complete responses. We don't see dramatic shrinkage of tumors. More typically, we see stable disease or slowing of progression. And for those patients, even though they might not have Child-Pugh A disease, are we impacting them? I think in my practice, I certainly offer them sorafenib. I have a little higher acuity for toxicity in that group. Obviously, we don't want to do any harm, and sorafenib, which is dosed 400 milligrams twice a day, or 2 tablets twice a day, has a very predictable toxicity profile, I think, in the GI toxicity and loose stool, the hand-foot syndrome, which can be very mild or very significant, and there's ways to mitigate that by prophylactically using urea-based creams. There was a study published in JCO just recently about prophylaxing patients for that. And I think the sense is that patients who are in the Child-Pugh B group are probably at a little increased risk for side effects affecting their performance status. So yes, these patients should, I think, be offered treatment if they're clinically up to be treated, and we just need to watch them carefully.
Thank you, Richard. And here it's important to notice that oncologists are geared to worry much about toxicity. But we heard from an expert. This is what Richard does every day. And I would like to ask Bob that it appears to be that the Gideon study, which was really a massive amount of data that came post-marketing of sorafenib, has shown some kind of particularities in the use of sorafenib between a hepatologist and an oncologist. Right. Tell us more.
Well, there's different thresholds for dose reduction and dose re-escalation. Some of it has to do with your personal or professional experience with the medication, whether you're going to follow strict guidelines, because the package insert doesn't even talk about dose re-escalation yet. Many of us do that, and we're comfortable with managing that. And I really want to emphasize, too, is that as a hepatologist, we stratify even our child's B patients between B7 and B9. There's a difference between a bilirubin of 2.1 and 4.9. So in the real world, we're talking about a real drug, real side effects, toxicities, comfort with dose reductions, re-escalations, managing side effects like hypophosphatemia, the fatigue that comes with this. You treat the fatigue aggressively, you may be able to re-escalate the medication dose.
And here to kind of like reiterate what we just heard. So number one is sorafenib is a drug that definitely will have potential side effects. But as we just heard from Dr. Finn, they are manageable. You can definitely look into them. You can try to adjust the dose. You can attend to the hand-foot syndrome by some therapies and support from dermatology. You can also try to adjust the doses. And number two, this can happen same way to diarrhea. It can happen in regard to fatigue. A critical component is that don't give up on your patient by saying, here we go, we give them the 400 milligram twice a day, can't tolerate it, this drug's not for you, move on. Actually, we have seen that the therapeutic potential for the drug is quite wide, and in other words, there's really high potential for adjusting the doses accordingly. In regard to the bilirubin, I know it's a little bit more challenging, especially if you don't practice necessarily and see that many patients with HCC. But we have noticed that actually, based on some guidelines that were published in JCO by Antonius Miller and others from CLGB, that a bilirubin of about up to 1.5, you can use the full dose, 1.5 to 3 of upper limit of normal, probably half the dose. Above 3 can become debatable, and this is where probably Richard's expertise come into play. And for albumin below 2.8, probably you need only 1 pill a day. If you're not sure, please, reach to any of our colleagues who are already available, because I would say that still there's high potential for that therapy to help out people, and don't give up on it very quickly per se. Now.